Pharmacology, gastrointestinal, anti-emetics. Nausea and vomiting are common conditions. Nausea is the unpleasant sensation of having the urge to vomit, and vomiting, or emesis, is the forceful expulsion of gastric contents. There are many potential causes of nausea and vomiting, such as morning sickness during pregnancy, gastroenteritis and other infections, migraines, motion sickness, food poisoning, side effects of medicines including those for cancer chemotherapy, gastroesophageal reflux disease and ulcers, intestinal obstruction, poisoning or exposure to a toxic substance, diseases of other organs such as cardiac, renal, or liver. Nausea and vomiting are common and are usually not serious. However, the healthcare provider should be contacted immediately if the following conditions occur: vomiting for longer than 24 hours, blood in the vomit, also cause hematemesis, severe abdominal pain, severe headache and stiff neck, signs of dehydration such as dry mouth, infrequent urination, or dark urine. The treatment of nausea and vomiting should be tailored to the cause. There are several medications that work on different neuroreceptors that, when used, can treat nausea and vomiting. For severe cases of vomiting, intravenous fluids or IV fluids may also be needed to treat the accompanying dehydration. Pathophysiology. The vomiting center can be activated directly by irritants or indirectly following input from four principal areas: gastrointestinal tract, cerebral cortex and thalamus, vestibular region, and chemoreceptor trigger zone. An important part of the emesis circuit is the chemoreceptor trigger zone, located in the area postrema in the brain. The chemoreceptor trigger zone is not restricted by the blood-brain barrier, which allows it to respond directly to toxins in the bloodstream, such as anesthesia and opioids. The CTZ also receives stimuli from several other locations in the body, including the vestibular center, visceral organs such as the GI tract, kidneys, and liver, the thalamus, and the cerebral cortex. The vestibular center and cerebral cortex can stimulate the vomiting center directly or indirectly through the CTZ. The vestibular system is located within the inner ear and gives a sense of balance and spatial orientation for the purpose of coordinating movement and balance. The feeling of nausea associated with motion sickness often arises from stimuli from the vestibular center. The gastrointestinal tract sends stimuli to the CTZ via cranial nerves 9 and 10, related to obstruction, distension, inflammation, and infection. The cerebral cortex and other parts of the brain can also stimulate a sense of nausea related to odors, tastes, and images that send these stimuli to the CTZ. The CTZ forwards these signals to the vomiting center in the brain. Pain can also directly stimulate the vomiting center. The vomiting center is located in the medulla in the brain. In response to the stimuli, the vomiting center initiates vomiting by inhibiting peristalsis and producing retroperistaltic contractions, beginning in the small bowel and ascending into the stomach. It also produces simultaneous contractions in the abdominal muscles and diaphragm that generate high pressures to propel the stomach contents upwards. Additionally, autonomic stimulation of the heart, airways, salivary glands, and skin cause other symptoms associated with vomiting, such as salivation, pallor, sweating, and tachycardia. Several neurotransmitters are involved in the nausea and vomiting process, and anti-emetic medications are targeted to specific neuroreceptors. The neurotransmitters involved in the nausea and vomiting process, the classes of anti-emetic medication targeting these neurotransmitters, prototype anti-emetic medications, and associated mechanisms of action. Each medication class is also discussed. The neurotransmitters and associated medications used to treat nausea and vomiting. Nursing considerations. 1. Assessment. When administering anti-emetics, identify factors contributing to the symptoms of nausea and vomiting so that treatment can correctly target the cause. Document the frequency and amount of emesis and effects on the patient's appetite and fluid intake. Assess for symptoms of dehydration, such as decreased blood pressure associated with tachycardia, decreased skin turgor, and decreased urine output or dark concentrated urine. If lab tests are ordered, monitor hemoglobin, hematocrit, and serum sodium levels for additional signs of dehydration. Implementation. Advocate for the most effective route of administration if the patient is vomiting. Consider timing of administration of antiemetics in advance of meals when appetite is affected. Follow drug label administration information and monitor the patient closely for potential side effects associated with that category of medication. For example, when administering anticholinergics and antihistamines, monitor for anticholinergic side effects, especially in elderly patients. Evaluation. Monitor for improvement of nausea and vomiting and notify the provider if expected improvement does not occur so that other treatment can be initiated. Continue to monitor for dehydration. Teach the patient non-pharmacological interventions for nausea, such as to drink enough fluids to avoid dehydration. If you are having trouble keeping liquids down, drink sips of clear liquids every few minutes. Eat bland foods. Stay away from spicy, fatty, or salty foods. Eat smaller meals more often. Avoid strong smells because they can sometimes trigger nausea and vomiting. If you are pregnant and have morning sickness, eat crackers before you get out of bed in the morning. Anti-emetic medication classes. Anticholinergics. Scopolamine. Scopolamine is an example of an anticholinergic medication that is often used to treat motion sickness or nausea and vomiting associated with surgical recovery from anesthesia and/or opiate analgesia. The mechanism of action. Anti-cholinergics block acetylcholine receptors in the vestibular center and within the brain to prevent nausea-induced stimuli to the chemoreceptor trigger zone and the vomiting center. They also dry GI secretions and reduce smooth muscle spasms. Specific administration considerations. The scopolamine transdermal patch is designed for continuous release of scopolamine following application to an area of intact skin on the head behind the ear. The system is formulated to deliver approximately 1 milligram of scopolamine to the systemic circulation over 3 days. It is contraindicated in patients with glaucoma. It has been reported to exacerbate psychosis, induce seizures, and cause drowsiness, confusion, and sedation. Due to its anticholinergic properties, scopolamine can decrease gastrointestinal motility and cause urinary retention. Nurses should perform more frequent monitoring during treatment with transderm scope and discontinued transderm scope in patients who develop difficulty in urination. Transderm scope contains an aluminized membrane. Skin burns have been reported at the application site in patients wearing an aluminized transdermal system during an MRI scan. Removal of the transderm scope before undergoing an MRI. The application instructions for the scopolamine transdermal patch. Only wear one transdermal patch at any time. Do not cut the transdermal system.